Okay, hello everybody. My name is Brian Condon. I work here at the Turning Point, where I'm a recovery coach, volunteer coordinator, and also a pathway guy, where I work with people that are taking medication-assisted treatment, and I work with them. And with me today, this evening.
Hi, I'm Barbara Vitalis, and I'm a clinical mental health counselor, and I'm also a certified alcohol and drug counselor. I presently work at the Brattleboro retreat inpatient units. I put on groups to various inpatient units, and oftentimes I work with those that have substance abuse issues. I also worked for nearly 3 years at Habit Opco, which is a methadone clinic here in Brattleboro. And recovery and treatment is something that I'm very passionate about.
Okay, and we're here to present Recovery Using Medication, RX for Hope. We don't have a very big crowd here tonight, but maybe hold the questions till later, because some of the answers may come up just in the course of the presentation.
Okay, addiction affects many people from all walks of life. Addiction does not discriminate, and 2/3 of American families are affected by addiction. Just speaking on a personal note, I have had 2 siblings of mine pass away as a result of their addiction. My oldest brother passed away in 1999 of a heroin overdose, and my sister just passed away 3 months ago from a suspected alcohol and opioids. So it's something that has touched me very, very dearly, and also I have many friends and colleagues throughout my life that addiction has touched their life in one way or another.
Okay, since we're mostly going to be talking about opioid addiction, the opioids goes back many, many years. I just found this recently, just to show how long that people have been using it. This was a reference about the opium poppy plant, where all of our opiates and opioids that we use come from heroin and pain pills and such. And this was in a Sumerian text circa 4000 BC. There was actually a whole article or whatever, if you want, about it, and they referred to it as the plant of joy and extolled all of its benefits.
This leads us to the dopamine connection. Dopamine equals a reward. Dopamine is a neurotransmitter or chemical signal in the brain. It's the feel-good and happy brain chemical. Most types of reward increase the level of dopamine in the brain. Dopamine plays a major role in reward-motivated behavior. It's a survival mechanism that in evolution made people eat, reproduce, and other things. All of the common addictive drugs, opioids, cocaine, methamphetamine, benzodiazepines, and alcohol, increase dopamine activity in the brain. Also, caffeine, nicotine, sugar, and other foods such as chocolate, especially dark chocolate, apples, bananas, and strawberries also increase dopamine. Whether chemical or physiological, addictions are made when our brain gets a dopamine boost over and over and over again. There's simpler things there. We could tend towards, eating these foods that make us feel better. But when you keep giving the brain things like opioids and cocaine and other drugs, it goes after that because it wants that reward, because that's the biggest reward that there is.
Fast and simple.
Yes.
Okay, opioid addiction is a chronic disease, which includes tolerance, physical dependence, cravings, seeking. It changes structure and physiology of the brain, loss of control, highs and lows, fear of withdrawal symptoms or being dope sick, and there's a high risk of relapse with this disease. All these make it a very hard thing to kick. A person addicted to opioids will do most anything to continue taking the drug, get more of it. And it's nearly impossible for a person to taper themselves off of the drug. You know, if a person thought, well, okay, I want to kick my heroin habit, I'll just take a little bit less, you know, but it's just not a simple thing for somebody to do, you know, 'cause they just know, start feeling a little bad, they know taking a little more will make them feel a lot better. And someone being able to walk away from opioids is very unlikely. There's a lot of public perceptions of medication-assisted treatment, or MAT, as we'll be referring to it this evening. There's a lot of strong opinions and beliefs among people, a lot of stigma and judgment, and including self-stigma, which I hadn't heard that word until a few weeks ago, but where someone that's actually in MAT will feel bad about it. I feel they're weak. You know, a lot of the other beliefs that other people have, they put on themselves, thinking I'm weak, I can't do this. You know, this is it's an easy way out. So that's a big problem with it. A lot of people feel they're not in recovery. There's a lot of myths and misconceptions towards it, and a general lack of understanding of what it is and how it works. Most of the people that I encounter that have a real strong negative attitude towards it, if I ask them a couple questions, they don't really know much about it. You know, a lot of their belief is based on some myth or just kind of a general knowledge, and you know, it's just a bad thing. But they're not usually basing that in kind of facts.
So, with that in mind, I'm going to do a bunch of true and false about MAT. And this isn't, you can think true or false in your head, but it's just kind of designed to show that there are a lot of myths when it comes to MAT. First one being MAT is just trading one drug or addiction for another. This is false. It's taking a helpful medication instead of a harmful drug. Just as medications for other illnesses, high blood pressure, depression, it's a medication that can work in the same way. True or false? MAT prevents true recovery. Again, that's false. MAT is an effective tool used in a healthy recovery. Many people have tools, and people that just go to AA or NA and they don't use MAT, they also have a toolbox that they can use, you know, coping skills to help them get through cravings or whatnot. Methadone rots teeth and bones. True or false? That is exactly false. 50 years of safe use in recovery has proven that this is only a myth. Methadone was developed in the prior to World War II. It was developed in Germany. They developed this because they were running out of opiates, and so they developed this synthetic opiate. And then after World War II, people came in and took what they wanted, and the United States took it and developed it for, tried to use it for, and found that it worked with those that were suffering from opioid dependence.
The original intention was for pain, you know, like on the battlefield and stuff.
True or false? People in MAT actually get healthier. That is true. By stopping the problem opiates and beginning to live a healthier lifestyle, their well-being improves because they're no longer putting impure street drugs into their bodies. They know exactly what they're getting, they know exactly what dose they're getting, whether it be Suboxone or whether it be methadone. They know exactly what they're getting, and they're not getting stuff cut with, you know, other dangerous, equally dangerous drugs. True or false? MAT is not appropriate for pregnant women. That is false. Evidence shows that the best outcomes for mother and child are with MAT. Again, if a mother is using impure street drugs, heroin, and going through the highs and lows of her, you know, the peaks of the highs and then the lows of the dope sick, that's not going to be very good for the infant or the fetus that she's pregnant with. And also there's a greater chance for miscarriage, or greater chance for the pregnant mother to overdose on heroin. There's still a withdrawal that happens for the baby once the baby is born, but it's a much safer, they know exactly what the baby had in utero. So that is important. MAT can play an important part in one's recovery from opiate addiction. That is absolutely true for all of the following reasons and many more.
MAT helps one's recovery by preventing withdrawal symptoms, reduces the cravings for that person, gives freedom from the daily highs and lows of active use. It allows the person to feel clear-headed and normal, so that way they can go on and actually do healthy things in their life, make some changes, instead of feeling sick or always seeking. And it can help stop the use of dangerous, unpredictable street drugs, which you don't, like Barb just said, you don't really know what you're getting anytime. And it allows the person to think of something other than the drug, which it can be all-consuming. When considering MAT, maybe also consider this. There's a lot of stigma, of course, with addiction, but there's also with MAT. And one thing to maybe compare it to is like cigarette smoking or smoking cessation. Smoking cessation often uses nicotine replacement treatment, kind of like MAT is replacing the illegal or whatever opioids with a safe, controlled one like methadone or Suboxone. But you know, everyone knows somebody that's used like nicotine patches or gum or whatever to help them quit smoking, and it basically helps them get through the cravings and stuff for it. And also similar to MAT, there's medications that are prescribed like Chantix and Zyban that people frequently use. And everyone I've talked to, you don't think of, if somebody's trying to quit smoking using something like nicotine replacement treatment therapy, they don't say, oh, that's terrible, you're weak, all this kind of stuff. Say, oh, good, I hope it works for you. And also comparing smoking to other addictions, smoking's also obviously very hard to quit. Some stats from the American Cancer Society, 40% of current smokers are going to try to quit this year, but only 7% of those will quit for the first time on the first attempt, and only 3.5% of those who try to quit without smoking cessation aids will succeed. So the stats don't look very good for someone quitting smoking either. And also, since addiction is a chronic disease, like diabetes, there's no cure for it. It's most often treated with medications, and it also needs to be managed with diet, exercise, and medication. And it's a condition which people relapse all the time. You hear people that their blood sugar skyrockets because maybe their medication wasn't quite working right, their diet kind of lapsed and they're not eating so good, but that happens, and then they have to escalate treatment and kind of reassess what they're doing, which is what recovery is and relapse from addiction to drugs. Hypertension, cancer, and many other conditions can be thought of the same way. I love this fact. People who utilize MAT are 60 to 70% more likely to be abstinent from the problem opioid at the end of a year than those who don't. So it increases their odds of actually not taking the heroin or whatever the drug may be.
Okay, I'm going to share a success story. I'm going to call my first success story John Doe number 1. He was very angry when he first came into the methadone clinic. Didn't like methadone, thought it was the worst thing in the whole world, but he knew that he needed help, was not able to do it without seeking out medically assisted treatment because he kept relapsing. So he just really, really angry. He would come to counseling, individual counseling, begrudgingly. Then he would stop coming, and then he would come and I would look at the clock and say, oh my gosh, is it almost over? Because all he did was complain. Eventually he decided, I want to taper from methadone. And as he was doing this, he had some personal things go on with his then girlfriend, and all of a sudden saw that he had custody of his older children that he hadn't really seen in many years. And he came to me and he said, I think I need to stay on methadone. I want you to help me. DCF is going to be calling you. I need to start working. I need to start doing something. And that was his family was his motivator. He says, I want take-homes. I said, you need to stop smoking pot. So, he said that was a tall order, but eventually he just said, I don't want it anymore. I want my family. So, lo and behold, 2 months went by. He started talking about his relationship with his girlfriend, how he needed to get out of that relationship because it was damaging to him. He said, I really want to work. He ended the relationship. He became sole provider for his 5-year-old son and his 2 teenage children. He said, I want take-homes. He started getting take-homes, which is they earn after a certain period of time. There's many things an individual has to do to get methadone on a take-home. He started with 1 bottle, 2 bottle, 3 bottle. By the time I left Habit Opco, he was almost up to 6 take-home bottles. It had been well over a year and a half since he had even smoked marijuana or even had the desire to smoke marijuana. And he was volunteering at his youngest son's daycare and becoming active in his community and enjoying going to community events, cookouts, and different, in his small community. And he had that willingness to turn around. And he said, I might be a lifer using methadone or having methadone. He says, but my mom says she notices the difference in me. People I haven't seen in a long time are like, wow, what happened to you? And he says, if this works, I'm gonna keep doing it. So that's my first success story.
Okay, now we're going to talk about the medications used in MAT. There's 3 basic ones: methadone, buprenorphine, which also known as bup. The one that most people know is Suboxone, the form of it, and also naltrexone. And there are also other medications used for other addictions that are also fall under the umbrella of MAT, such as Camprosate, Camprol, and Antabuse for alcoholism. A lot of people take those. And also naltrexone is often used for alcohol, so that is kind of more prominent for it. So methadone is an agonist, which means it's capable of fully activating the opioid receptors, full or partial pharmacological response. It is a synthetic agent that has been used for close to 50 years for treatment of opiate addiction. And basically it works by tricking the brain to thinking it's still receiving the addictive drug, and by occupying the opioid receptor site. It blocks the euphoric effects of other opioids, including itself. It's got a ceiling effect where if you take more of it, it's not going to, you're not going to react more to it. And it also, if you took additional drugs, say you took the methadone and went out and you took heroin or something afterwards, it limits the effect that you'll get from that. There is a psychological effect. Some people will use it and then go out and then think that they're getting really, really high, but that seems to be a more of a placebo effect. They think they are, so therefore they are. It reduces cravings and withdrawal. With stable dosing, it does not cause euphoria or intoxication. With the correct dosing, it doesn't make people fall asleep. It's often you see people that are on methadone treatment or Suboxone nodding off and stuff, and if they're getting the correct dose, that does not happen. It can be for other reasons and stuff too. And it's got slow excretion, which allows once daily dosing. It's got a 36-hour half-life, which means you can go once a day to the clinic and get your dose, then that covers you until the next morning when you go in. If it was a shorter half-life, say like heroin has a 4 to 6 hour half-life, so if you want to keep the same effect, keep the same level in your brain, you would have to use again, take more of it, every 4 to 6 hours, like aspirin or whatever. But this is like say a 24th hour thing, so therefore they can be used for to help with opiate addiction by that you don't have to go every 4 hours for it, which we wouldn't work if you had to go back to the clinic every 4 to 6 hours. It's kind of tough already just to go once a day.
It's a big commitment.
It is, yeah. It's dispensed only in specially licensed clinics by specially licensed physicians. They must go to the clinic daily to get their dose. As Barbara was saying before, you can get take-homes after a while when you show stability, your urine analysis, they check frequently, you're not taking other drugs and things like that, and then up to the 6 take-homes. Basically, you just go in once a week and you get to that stage, which takes a while. And then also, they have mandatory groups and counseling that goes along with a treatment plan that they agree to. Little fun fact, before Bayer introduced their aspirin to the world, 1898 to 1913, they sold Bayer heroin to 23 countries with the American Medical Association stamp of approval. It was sold over the counter as aspirin to this day. You just go in your neighborhood pharmacy and buy it. No big deal. It was useful for cough and pain, and finicky babies and things like that. It kept them kind of quiet. It was used for things like that. It was actually Bayer that came up with the name heroin. It's their testers they were doing said they felt heroic when they were taking it, so let's call this thing heroin. It's actually a bottle of what was sold back then. They took it off the market after there was a lot of reports of addiction happening. The next MAT drug is buprenorphine, Subutex, Buprenex, which is a partial agonist. It's capable of producing opioid effects at receptors, but less than full agonists like the opioids and methadone. It provides relief from cravings and withdrawal. The drug most commonly used and known is Suboxone, which is buprenorphine with naloxone, which is an opioid antagonist, the opposite of agonist, and that helps prevent misuse. Naloxone alone is known as Narcan, which is very useful in treating people that are overdosing from opiates, especially heroin and stuff. It's like in a nasal spray, or it can be injected also, and it blocks the receptor sites in the brain, kicks all the opioids off of them, and then the person starts breathing again, basically, and stuff. Another interesting thing too, there is opioid receptors all through the body, not just in the brain. And that's basically how, if a person's overdosing on opioids, their breathing's really slow, shallow breaths, and then it eventually stops if they're overdosing to that degree. And that's because of opioid receptors in the respiratory system. And that's also, there's people that take a lot of it, including methadone, can have like constipation and other digestive problems. That's from all the opioid receptors there. It also has a ceiling effect, where the person reaches the plateau where taking more of it is not going to have any additional effect. If a person, this is, there isn't like a lot of street Suboxone. Sometimes people do it because there's a long wait to get into clinics. They want to treat themselves before then, and there is a market for it and can be found. But also another reason that it's bought on the streets is if a person is not actually addicted or physically dependent upon opioids, if they take Suboxone, they will get an opioid high from it euphoria. But if a person's physically dependent and addicted, so to speak, it doesn't have that effect on them until they get addicted to that, and then they're in the same game. The dispensing of it is also by physicians with special qualifications. If you can get it at clinics and stuff, often you start out, there's a hub and spoke we'll talk about later, where you can get treated. But it's also prescribed by private providers. You can get it filled at like any pharmacy and stuff. It's taken once daily with the possibility of every other day or even every third day. But usually it's most every day. At centers, you start taking it daily, and then you might get take-homes later. It's usually taken as a film which dissolves under the tongue, and that's to prevent diversion. Once it gets under the tongue, it gets really gummy, and which makes it really hard for a person to with a pill before they can kind of cheek it and maybe take it out and then use it to sell or something like that. But with this, the thought is to get something that, even if they pull it out of the mouth right away, it's going to be almost unusable. And it started when a patient's in the early stage of withdrawal, usually 12 or 24 hours of abstinence. The third drug is naltrexone, which has gotten a little more attention recently. Brand names is like Revia, Depade, and most commonly heard of now is Vivitrol, which is an injection. It's an opioid antagonist, which means it blocks the opioid receptors. The person won't feel high if they take an opioid when they're on this medication. But some of the downside, so to speak, where it's not used as commonly as methadone and Suboxone is it does not reduce cravings or withdrawal. And the person must have stopped all opioid use 7 to 10 days before, which makes it tough to transition to, okay, I'm stopping taking and I'm going to take naltrexone as my MAT medication. You have to go to 7 to 10 days. If the person does not wait the 7 to 10 days, they go into basically instant acute opioid withdrawal, and it's often a protracted withdrawal, which lasts for days, I guess, and very unpleasant. There was a lot of poor compliance with the tablet stuff. People could plan their own relapse. I'm just going to stop taking this, and then tomorrow I'm going to use. But with Vivitrol, it's a monthly injection. Then they have to go to a doctor's office. They can't get it filled at a pharmacy or something, and that improves compliance. They can't plan it themselves as long as they go to the doctor every month. And there's also implants that can be done that can last 3 to 4 months. The overall effectiveness is lower than methadone and buprenorphine, but it does have its place, especially in a stable and motivated person in recovery. It can work for the right person, maybe somebody that's been in recovery for a while. They just want one little thing to help them carry on with that. And it's also a non-opioid, so it does not develop any physical dependence. You can stop taking it any time. It's not going to have any ill effects to the person. Assessment and treatment plans go with anyone prescribing MAT for somebody. Basically, they meet with a doctor, they get a physical, they look into their whole history of use and their whole physical history. The patient learns about treatment choices, and then the patient and the doctor and the staff decide if a person is right for it and what drug also. And one misconception is that anyone that asks for MAT gets it, but not every person does. They look into things like the length of the person's addiction, the quantities they were taking, and prior treatment and recovery all go into the decision. So sometimes a place will say, well, this is your first time trying, why don't you try abstinence? Why don't you try meetings and things like that? And for people that doesn't working for, then we can escalate it up to using MAT. But it's not necessarily the first thing that you go to. Medications are started carefully. A correct dose is found when the person feels normal, not high, not sedated, but it's also not feeling withdrawal or cravings. Falling asleep again does not occur at proper doses. Adjustments can be made ongoing, and usually at least 12 months of taking the drug is recommended to allow the person to stabilize and hopefully really work on the recovery. Now that they're feeling okay and they can function, they can work the recovery and get to a place where tapering down can work for them. Taper should be done slowly. They just stop, they just reduce the dose, over a long period of time. And if it's done right with the proper doctor's care, the person can be pretty much withdrawal and craving free. I love this fact here. For every dollar that's spent on MAT, at least this is in America, yields $38 in savings in things such as healthcare, law enforcement, prisons, unemployment, criminal activity. This is actually 7 times higher the savings that was previously thought. I've heard a lot of quotes about $4 for every $1 spent, but this study here, published by drugabuse.gov, shows that it's that much. So if people complain about spending the money, for MAT, and most people that do get Suboxone and methadone are on Medicaid, and so it's the people paying for it. But $38 return on $1 investment is pretty good. I wish my investments paid off that well. So.
Okay. So, is the Substance Abuse and Mental Health Services Association, or SAMHSA, states that recovery is a process of change, excuse me, through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Am I not doing this right? Okay. The goal of MAT is to recover from addiction. It's not, I mean, the harm reduction, there's a lot of harm reduction. People aren't using needles anymore. There's a cut down in crime from stealing and whatnot. But the goal of MAT is to recover from addiction, is to clear the mind, free of withdrawal symptoms, cravings, and drug seeking opens the door to changing addictive behaviors and exploring everything that can make up someone's recovery. With help, as in all recoveries, a person can address many things that active addiction damaged. Somebody may have been trying to medicate themselves, using drugs for their depression, their anxiety, whatnot. Once they're in MAT, they can start dealing with those things. Hey, what's going on with my anxiety? What's going on with my depression? It's now possible to start repairing relationships with family and friends, to improve one's physical and mental health, return to forgotten passions, find new interests and activities, and work towards becoming a person that they want to be and now can be. I don't know how many times I've asked people with addictions, what do you like to do? What do you like to have fun at? I don't know. I forgot. I haven't had fun in such a long time because everything that I've done is, drugs for the last 10 years. Okay, well, what did you like to do before drugs took over? Well, I like to go kayaking, or I like to go fishing, or I like to do this. Well, do it again. Try it again. And people find what they like again. And getting those family relationships back. Like the gentleman I spoke of, his mother, he had said, was so against him being at the methadone clinic because, methadone is so bad for you and everything like that. And then, he was at the clinic for 2 years. He's on, 6 take-homes. He's volunteering here and there and everywhere. And she said to him, you know what? And this is what he told me. She said, I'm proud of you. You've really done a wonderful thing with your life. I'm really proud of you. And he was telling me this and he had tears in his eyes. And this was not a man that was prone to being, emotional like that. So it was so important. And it was so wonderful to see him be that happy and have people be proud of him. So when people are in recovery, working at the retreat now and when I was at Habit OPCO, come to the turning point. There's peer recovery. There's recovery coaching. If AA, NA, whatever doesn't work for you, or if you want it in addition to that, come here. It'll help. Self-care. Brush your teeth. Get some sleep. Do things that are, taking care of yourself. Go and get a checkup at the doctor. Go to the dentist. If people had counseling and therapy, when I was working at Habit OPCO, we were only able to really address their addiction and not their mental health issues because it wasn't licensed for mental health. So I would make referrals to mental health clinicians so people could address their mental health issues. Again, coping skills, learning to deal with life's challenges, education, spirituality. A lot of people I worked with went back to school, said, hey, you know what? Before drugs hijacked my life, I was going to school to be an early education teacher, or I was going to school to be a nurse. Guess what? I've gone back to school, and that's wonderful. So employment, volunteering. I have suggested people, come volunteer at the Turning Point.
Absolutely.
Just rediscovering or finding new and sober activities and having fun. And discovering things they're passionate about and finding a purpose in life.
And as we kind of mentioned before a little bit, recovery is the goal of MAT. That's the hope for everybody. But you can't avoid or dismiss the harm reduction side too. Sometimes people will start using MAT, whether it be Suboxone or methadone, just because they don't want the highs and lows of the active use. They don't want withdrawal. They don't want to be feeling dope sick anymore. And some of those people will get in there, and that'll give them what they want and stuff. And that itself is a good thing. But also, a lot of people too that I've spoken with that are doing really, really well now will have gone in just for those reasons, just they didn't want to feel sick anymore. They weren't interested in recovery and all this other stuff. But later on, they're feeling okay, and they kind of see that there's more out there than just being okay, and then their recovery starts. And maybe 6 months later, or 2 years later, but it often happens. But at the very least, if they're in MAT, they're not using substances with unknown makeup and strengths. They're not buying drugs in the street. They don't know what's mixed in it, how strong it is, how they could overdose. The dosing is safe and controlled. It's prescribed by a doctor with special training. And it's also not obtained through criminal acts. So by doing this, you're not perpetuating, street crime, drug cartels, and you name it. And it's usually paid for by health insurance, eliminating the need to get money through questionable means. So people trying to pay for their habit aren't breaking into people's houses and doing things like that because it's all paid for them. The medications have properties that discourage the taking of the problem drug. So they're much less apt to go out and still be taking illegal drugs. And they're also not using needles, which reduces the exposure to diseases like Hep B and C, HIV, and other ones. So all those things are really important things to look at. At the very least, even if they're not getting into recovery and stuff, they're much safer, and also the community is a safer place.
Okay, another success story. I'll talk about John Doe, number 2. This was a very young gentleman, 24, 25, very intelligent young man. When I first met him, I thought, I was very brand new to the methadone clinic, and I thought, wow, it really does hit all aspects of life. Came from a really pretty well-to-do family, and really kind of a serious person. And he had started out, as many people start out, with their addiction to opioids. He was prescribed, due to a sports injury, he was prescribed oxycodone. Found out that oxycodone made him feel not shy anymore, made him more loose. Oxycodone became very expensive, so he started using heroin. And when he came into treatment, he was using a bundle of heroin a day, which is 10 bags of heroin. So he was spending about $100 a day on heroin. And he came in, he originally wanted Suboxone, but it was not available at the time. So he really didn't want to do the treatment, but said, you know what, I got to do something. I can't live like this anymore. And so he started very low dose and worked his way up to a pretty high dose, or an average, I might say an average dose. And about a year and a half later, he came to me, and he attended group every single week, was extremely insightful. I mean, this guy was like, he had such wisdom. But anyway, he came to me about a year and a half later, and he says, I want to taper from methadone. I don't want to be on methadone. This was my plan. I don't want to be on it anymore. So what do you recommend? I said, let's go slow. Let's go real slow. So we did. It took him a year to get out of the methadone clinic, but he did do it very slowly, and continued to do groups all the time, continued, he had a couple of times where he stopped and said, I'm starting to not feel well, I'm going to stop the taper, which he did, and eventually he tapered completely out, and to my knowledge, very active in the 12-step community. That was very important to him the entire time he was in treatment, was the 12-step community. And, he was somebody that did not feel like MAT was going to be with him for his entire life, or for a long duration of time. But something that MAT worked as that tool for him for that period of time, and was very successful with it.
Okay, briefly I'll talk about the Vermont hub and spoke system. Vermont is the only state in the country that has a system like this. And it's basically for providing medication-assisted treatment and supports for people who are addicted to opioids to help them get better. It started in 2012 and has expanded over the past 3 years. The basic goals of the program are to provide access to treatment, whole person approach, where they want people to go see their doctor and take care of other health conditions, maybe mental health conditions, prevent drug diversion, provide effective treatment for their addiction, and also seamless care. Basically, a person would start out in a hub, the middle part, which is a clinic or whatever. Here in Brattleboro, we have the Brattleboro Retreat, which does the Suboxone, and we have Apodaca, which does the methadone. So we're really lucky here in town that we have this hub and one like that. So a person can start out with that, seeing a doctor, getting prescribed, getting all the counseling they need, the groups, that kind of stuff. And as a person progresses, if they're on Suboxone, they can be referred out to like a primary care doctor that's licensed to prescribe Suboxone. And they can just go see the doctor, however, once a month or whatever it may be, and get it prescribed, pick it up in the pharmacy. And even the spokes are the private care physicians that do this. And they also work with making sure the person has the whole care, taking care of the whole person. Not just here's a prescription, good luck with that.
Right.
So it's been very effective, and it's got a lot of people in treatment. It's still growing. There are waiting lists around the state. We're very lucky, again, in Brattleboro, where there is no wait. But in the Burlington area, it can be a very long wait, unfortunately, for someone to, and that's very unfortunate. If a person's motivated, they want to quit, they want to get better, if they're told they have to wait months and months. But it is improving, and there's more and more people interested in treatment, and the wait lines are still going down. So they're moving definitely in the right direction, and they're expanding and improving it constantly. But it is, a kind of slow process.
Definitely.
In your handouts, a little more information about it and stuff, but basically just what I said. One thing we wanted to cover too is like how you can help somebody that's utilizing MAT in the recovery. A lot of people ask me this, what can I do to help? What should I say? I don't want to enable somebody, I don't want to do this or that. But we came up with a partial list here, and everyone's different. It can definitely vary person by person, but the first thing they could do is just by having an open, non-judgmental mind, where if you're trying to help somebody and you can't condone the fact that they're on MAT and you let them know that or give that impression, you're not really helping them. Mm-hmm. And one thing I'd like to point out too is that the people that do utilize MAT in the recovery encounter stigma and judgment every day.
Yes.
Definitely, I work with a lot of people in MAT, and I talk to even more. And I think they all, at least one day, have somebody tell them that they're stupid. This is the weak way of dealing with it. You should just quit and all that other stuff.
You're so right.
Yeah, and it's, and that's not a great way to help somebody by, they chose a path, they're trying to get better, and we tell them that they chose, not everyone, some people are telling them they chose the wrong path. So by, just keeping that in mind of the person you may know that they encounter that kind of stuff and could use a little more support. And just basically understanding that there are many paths to recovery, whether, if you're a person in recovery, that may not have been the path you chose, but if it's the path they chose, we should honor that. It's one thing with the turning points that we welcome all paths to recovery. Everyone what works for one person may not work for another one. So find what works for you. Try to give them encouragement and support. Recovery is not easy for anybody, no matter what your path. So realize that and acknowledge it. Having empathy, understanding, and some knowledge, which hopefully this is helping with, can go a long way for helping somebody that's utilizing MAT. And probably the best thing you can do is just ask them, what can I do to help? What do you need from me? As long as it's not something that is going to endanger them or whatever, because they still are a person addicted to drugs, but, what can I do to help? Maybe just listening to them or, whatever that person needs. And there's summary. MAT is not the answer for everyone. There's a lot of paths to recovery, and abstinence and 12 steps and all these other things work great for a lot of people, but they may not work for some individuals. So not for everybody, but it can be a huge help for a lot of people, and we see it all the time. I talk to people all the time that are doing really well, and even when they started out, it didn't look promising or whatever, they didn't have much hope, but slowly, with the help of this and working, they find the hope and make changes. And also, for most, just entering into MAT is a huge step. It's making a decision to, okay, this is my life. I'm not happy with it. I feel bad, but I'm going to make a change. Change is never easy for anybody. It's a very scary thing. And for a person to make that step and go into the clinic and see the doctor and get physicals and all this kind of stuff, it's kind of a scary thing and kind of a big step. And they're doing this.
Yeah, definitely, Brian. When I was working at Habit Opco, the shame that people would bring with them on the intake, and part of what I did when they came to the intake was just to let them know that it was okay and that they were making a good choice coming for treatment, and that they had nothing to be ashamed about anymore, because they were just doing, but they bring so much with them because of the behaviors that addiction has, and they just didn't want to do that anymore. They were so done with it, and they just wanted to move into a place where they could start healing. And I would let them know, and the other counselors as well, would let them know that they were making that first step in their quest for getting help, which is really hard to ask for.
And just the motivation it takes, taking that step and also continuing with it. I've heard so many times people say, like, I saw those methadone people out at the bus stop. They're out there every day at 6, and they'll think it's a bad thing, it's negative. They're judging them and stuff. Like, it's like, and my response is, yeah, they're out there at 6 a.m. waiting for a bus that is going to drive them from Bennington to Brattleboro or whatever, and they'll be on the bus for 2 up to maybe 5 hours just to get something that's going to help them improve their life, help them get better. That's a lot of motivation.
It is. A lot of dedication too. A lot of dedication.
Getting up at 6 or getting out the door at 6 and then not getting back till noontime or whatever isn't a fun thing, for anybody. If you bring their kids with them and stuff, so that's a huge thing. But it's not a negative thing, like some people perceive.
Right.
And recovery is a never-ending process. That's not easy. It's a bunch of small steps. That's usually the way it works best. It's a bunch of small steps and little successes, and these people every day find the will to continue with that. And keep improving their lives, and they can find themselves in all kinds of great places. And I see it all the time that people have happy, healthy lives, and they're really doing something. They've got purpose. They've got drive, and it's made all the difference. And a lot of them tell me that they wouldn't have been able to do that without MAT. That they had tried the other, tried abstinence and everything else, but it didn't work. But MAT, saved their life. That's a quote from several people I know.
Oh yes, yes.
Okay, that's the end of the presentation. We'd like to field questions, or maybe possibly have a discussion. If anybody has some thoughts. Yes.
I had heard about the hub and spoke. I heard that name before, but I didn't really know what it was. So it's nice. And so the hub is like the medically assisted treatment, and the spokes are like the 12 steps, or
no. I'll let you go.
Oh,
Yeah.
the spokes are individual doctors, where people can't go there for methadone, because you have to have a clinic, special license for methadone, but you also have to have a license for Suboxone as well, but it's a little less regulated. So you have to you can go to the doctors, like an independent doctor, without going to a clinic. Like the Brattleboro retreat, they have a hub, and I think they also have a spoke. And so people go to, if they also want to go to like an independent doctor, like you have a primary care physician. Some primary care physicians also deal with Suboxone as well. So that's kind of like it. I mean, I don't know all that much about it. I'm still kind of learning myself.
It's basically all these like private providers,
Private providers.
primary care physicians that do prescribe
Yeah.
Suboxone. They're all working together basically, so it's not just, this person here, there, or whatever, but they're all in communication, and they all have people from the state. The state runs the hub and spoke system.
Right.
So they have all these resources, and it just ties the whole thing together, including other things that, don't have necessarily to deal with the prescribing of the medication, but things like mental health,
Yeah.
counseling, and all these other things. They try to tie it all together and make sure that all these things are accessible for everybody that wants to utilize MAT.
Right. Yeah, exactly.
So that's basically how it works, and that's a great place for anybody to start if they're, if they want to just find out about medication-assisted treatment. Is like to call the local spoke, call the state even, and then they can be referred to, who to see, who to talk to, and how to go about it.
Spokes generally, I think, have less, like the hub to begin with, like with methadone, it's daily dosing until people can get like on take home. And then with the hub to begin with, I believe it's daily dosing too. And then the spoke is more like a prescription type
Yeah.
thing.
And a lot of times it's a progressive thing. A person will start out, like say it's Suboxone, they start
Yeah.
out at the hub, they
And then they
do
can
well
go-
with that, and
yeah.
then they're doing well 6 months, a year later, or whatever. They can be referred to a primary care physician that prescribes, and then can start seeing them.
Right.
But the hub is the place to start generally.
Right.
I think with all of the whole situation, that there's always that continuum of care where you get it through therapy and doing your roots and doing everything else, as well as getting your medication, which is a huge part of
Oh yeah,
Right.
definitely.
intrinsic,
Yeah.
Mm-hmm. Definitely.
Can you repeat that for that, what she just said?
Yeah, basically, she said like it kind of encompasses all the different parts of it, so it's not just prescribing, but it's all the other elements.
Right, the whole
but-
continuum of care.
Yeah, exactly.
Yeah.
And the hub and spoke also make that, even like, because there was, before the hub and spoke system, there were primary care physicians that could prescribe Suboxone, and they did. But with the hub and spoke system, they have access to people working for the state that can come into their own practice and stuff, and provide counseling and things like that. It's just made it much more available, and also gives better oversight on the primary care prescribers, that they are offering the whole spectrum of care for the person, not just here's a script, and
Right.
come back in 3 months,
Right.
that kind of
Right.
stuff. It's a lot of oversight and stuff, and it's really helping a lot of people receive the whole.
Yeah, the whole
Picture.
thing. Yeah.
I think one of the myths is that there maybe that the medicated assisted treatment still makes them high, just not as high. Like I wonder if there's the thought that it's not making them feel normal, but it's just kind of like it's like having 2 drinks so that you don't get the shakes or something versus or whatever. I just wonder if some of that is that they're still looking at them in their addictive process versus in recovery. I don't know.
Yeah, and it could be. I mean, a lot of times, I've heard, especially when I was working at the methadone clinic, I heard, I would have people, from outside agencies call me, and, I had an appointment with so-and-so today, and, they were falling asleep on me, how much methadone are they getting? And that would be a red flag for us to say, something's going on with this person. They're adding to their methadone, either taking maybe benzodiazepines, which can add to the sedating effects of methadone, or they're using, heroin or some other opiate on top of it, or some other sedating tranquilizers or something. And that would give us the kind of red light to do more, maybe drug tests, and have a conversation with the individual to see exactly what's going on, and see, okay, how can we help you? We hear that this is going on, so, and you're using something that you're not supposed to be using, so what can we do? What extra help can we give you? And oftentimes we might refer that person to starting now, or maybe a residential place like Valley Vista, if that's the case, if they are supplementing. Because a good dose of methadone, people should feel normal and not be nodding out. And the same thing with Suboxone too. But I'm sure that's one of the reasons is they're still getting a drug.
Right.
Yep. But I just wish that people would see that, people are getting drugs for, you wouldn't ask somebody that was suffering from, bipolar illness, oh, when are you going to stop using those medications for your bipolar illness? Nobody's going to do that.
Stop taking that insulin.
Yeah.
Aren't you ready yet? Just stop it. Just stop.
Yeah. Exactly.
I think the Department of Corrections is one of the worst offenders on that particular,
I agree with you.
and I think they're making a huge transition right now. I think they're
Good.
getting much better, at least most of them are getting much better at
Good.
changing their, if not their real attitude toward it, understanding that political correctness is that they have to be such and such a way.
Mm-hmm.
And so they're trying to change their attitude toward what they need to be doing. So.
Right. I've worked with probation officers who have been very supportive of a client. But then I've worked with probation officers that are like, how long are they going to be on this? It's okay. They've been on it for 6 months already, and they're still using once in a while. Well, maybe we haven't gotten to the crux of what's actually going on with them.
Or flat out saying they're just trading one drug for another.
Right. Exactly. Yeah. So, but other probation officers have been extremely supportive.
Yes.
So, it really depends on the probation officer. Some aren't willing to hear the evidence.
Yes.
My question is, could you kind of describe for someone who was considering MAT what the early stages of transitioning might be like? Because I think someone might be very frightened to make that kind of step, and it might be helpful. It would be helpful to me to know what that transition is like and what they can expect and how they can expect to feel. If you can expand on that at all.
So somebody that's been a drug user,
Yes.
an opiate user, and they're coming into treatment,
Yes.
they're still going to feel maybe crappy to begin with. It's getting them to a dose that feels comfortable for them. And sometimes what's comfortable for them sometimes people who are addicted to substances, to opiates, might think more is better. It's not always the case. But they might feel not too good for a few weeks, even, a couple of months. They might feel really uncomfortable and still have some symptoms. But that's up to the doctor and the nurses and the counselors to get them to a dose that makes them feel comfortable. That where they're not craving anymore, they're not getting sick anymore, and they're just kind of level. And people have gone, when I was working at the methadone clinic, some people were, they're doses got to be where they'd come and see me, I gotta go down on this. I'm falling asleep. We love those kind of people because they were very honest, saying, I don't want to be falling asleep. I want to feel this is too much for me. And so we would, titrate them down rather than up. So to begin with, people, I don't know about Suboxone, but I know methadone. People are going to feel not good for a little while.
There's no like one size fits all dosing. It's not like, oh, you weigh this much, this is the dose
Yeah.
you need. It really depends on,
Yeah.
how much opioids they've used for how long. So there's not any like real strict formula you can follow
Yeah.
to what a person needs. It's,
Yeah.
fine tuning.
Right. And Dr. Kloster, the doctor at Habit Opco, would always say that he'd always use like a gasoline tank to explain to the patients, clients coming in, you're here and we don't want to get you up here. We got to get you to the right level. So, I mean, I can't do it like he does, explains it, but it's a really, really good explanation. And they've got to go up slowly because methadone is a really powerful synthetic narcotic.
But the process of going in and like seeing a doctor and starting on
Yeah.
it, they make it as simple as possible.
Yes.
Shouldn't be traumatizing or anything.
No.
It's still it's a brave step, but then there's a lot of extra help in the beginning. They see a counselor, or more often, and then somebody later on, and,
Yeah.
things like that. The
Yeah.
care they get is at a lot higher level when they first start.
Yeah.
And then as they adjust and stuff, it can decrease as appropriate.
Right.
So
right.
they get a lot of extra care and attention when
Yeah.
they're starting out.
Yeah. Yeah, definitely. Yeah.
A lot of compassion.
Yes. Compassion's a very powerful thing
Yeah.
with this. Yes.
I was curious, the methadone chemical composition, you said it lasts how long in the body?
This has a half-life of 36 hours.
That's,
Yeah.
It's the physiology of the human species that makes it prolong that,
Yeah.
I was curious.
Yeah, that's just where it is.
Yeah.
The chemistry of it, I have no
Yeah.
idea. But so yeah, that's just like any medication they've got a certain half-life.
Yeah.
Whether metabolism and things like that, I have no idea. But
Yeah.
that is it, and that makes it an effective tool for something like this, where they don't, it covers a person for that good period of time, so they're not. When they go in during the same time frame each day, they're not going to be feeling withdrawal or cravings before they get there, and things like that, or feeling bad in the middle of the night, things like
Yeah.
that.
At first they might, when they first start.
But once,
I don't know if this is a myth, but I knew somebody whose brother was using heroin and he tried to stop himself, and then he had called the retreat and they told him that he had to actively have it in his system in order to get the treatment. And I don't know if that was a myth or if you're trying to kick it yourself and you say, I can't, is there a certain, you need to have it in your system or you shouldn't have it in your system before?
I don't know.
You don't know.
No.
Yeah.
I mean, all I can speak to is that, working at the retreat, I work inpatient.
Oh, sorry. How
yeah.
about at the
Habit Opco. Sometimes they would take patients that had been in jail, that had not used anything. And when they came out, they were afraid that they were going to start using drugs again. And they didn't want to. So it was used as prophylactic, and pretty low dose,
right.
but not, but just as a precautionary type thing. Yeah. But their records were looked at. It wasn't like an automatic. Their records were looked at. Yeah, exactly. That they had a history of opiate dependency and stuff like that. But normally, when people came in to Habit Opco, we're looking for the opiates in the urine. And if somebody says, I just used today and the opiate's not there, no. Yeah, we're gonna do a little bit more digging.
We were talking about the implants and the
Yes.
fact that you could do it with something, but you didn't mention it with Suboxone, but they're now doing it with Suboxone now in some test studies that began.
Oh, I wasn't aware of
Really?
that.
Oh, wow.
Yeah.
Wasn't aware of that.
Yeah.
Wow. Interesting.
Yeah.
I'll have to look that up.
Yeah, when I mentioned it earlier, that was with naltrexone.
Yeah, I can remember the name.
Yeah,
Yeah.
yeah.
That was a shot though, wasn't it? Was it a shot or?
Well, they started out with
This is-
tablets,
yeah,
like
this
once
is
daily tablets,
like
but
birth control.
with naltrexone, it's most commonly, the most effective way is Vivitrol, which is a monthly injection. But there's also implants under the skin that can last 3 or 4 months also. And one thing I neglected to mention about naltrexone, one of the problems with that, if somebody plans their relapse from it, they've been not taking any opioids at all, and even like methadone and Suboxone, which is an opioid, their tolerance goes down. And if somebody
Yes.
plans their relapse and they go out and they start right back up where they left off, they're most likely going to overdose.
Yeah. Yeah.
So that is a consideration also in that, they're not thinking that their tolerance has changed tremendously by being clean of the opioids.
Right.
Then that can lead to problems.
Also, I also wanted to mention too, if people are on methadone or on Suboxone, going to a clinic, whatever, and they just stop like that, they're gonna get sick. Because it's meant to, if somebody wants to taper, they gotta taper. And if they just stop it, there's going to be a withdrawal happening.
And that's where some of the people that say, oh, getting off methadone was horrible, I'm so sick, and things
Yeah.
like that,
I
are
know.
often people that get frustrated, fed up, they don't want to
Yeah.
go every day and stuff like
Yeah.
that, and they just stop.
Yeah.
And you just really can't do that and expect
Right.
to feel okay,
Right.
because you have to taper down,
Right,
and very slowly, preferably.
right. And then they might blame the substance, the
Right, yeah.
medication that
Yeah,
they've been on.
methadone's bad, this
Right.
happened to me, but
Right, right, exactly.
have to take into account how they did it.
Right, exactly. Yeah.
Anybody else? Okay.
Okay,
Well,
thank
thank you all very
much.
much for coming. Really appreciate it.